series. We're so excited to be joined today by a CEO who has made his name in the industry in ways that you're about to find out. My name is Amy Stevens. I'm the General Manager at Innovaccer over our provider performance and innovation. And here with me today is David Thorpe. He is the CEO and co-founder of Upperline Health. Welcome, David.
Thank you so much for having me.
We're excited to have this conversation today. I'd love to hear a little bit about you, your company, and how you got from being you to running this company.
Yeah, so I'm born in New Orleans. Upperline is a street. It was a restaurant as well that closed, unfortunately, during COVID, but it is still a street. And moved from New Orleans, grew up in Birmingham, and then I've been in Nashville for roughly 15 or so years now. I got into healthcare as an early employee at a company called Aspire Health, which was an end-of-life palliative care company. And that was really where I sort of got passionate about value-based care and changing the system with that. And really the impetus behind Upperline was wanting to do value-based care in a specialty setting. There's just not a lot of that happening today, even though it's the majority of the healthcare system. And so we started Upperline 6 years ago with that goal in mind, and have grown from there.
So talking about the growth that Upperline has gone through, love to hear about the company itself, how you built it, how you've brought so many different physicians together. And I know you're already in several states and you keep growing. Talk to us about how you're thinking about where you've come from and the future ahead.
Yeah, so we started 6 years ago in Birmingham, Alabama with 2 practices and 2 doctors. And so we were very bootstrapped for the first year, which was intentional. I think myself and Stephen, we wanted to sort of experience the small practice life that a lot of the physicians live. And I think we got to experience that. Had some very funny stories of staying in cheap hotels with bed bugs and those types of things. But also got to experience, for business purposes, more importantly, what it's like running a practice when you're trying to do something strategic. We weren't seeing patients, right? We were full-time business people. But it's even hard with 2 full-time business people in a practice of 6 doctors, trying to manage, when a front office person doesn't show up for work and the types of things that our physicians that are independent in particular are dealing with day in and day out. And so got a really great taste of that and appreciation for that in a way that I don't think we would have otherwise. And after about a year, we ended up partnering with another investor at a Boston Silversmith Capital, and grew pretty quickly over the following 3 years by mostly acquiring practices. And as we went to do that, we had a couple things in mind that we were very intentional about. First is we wanted what we always call a fee-for-service chassis. And we could talk a little bit about that, but we wanted to be able to play in value-based care and fee-for-service and go between both. It allows us to go really deep in our markets and be really present in the communities. It allows us to see all patients as well. And I would say sort of most importantly for us as we think about sort of the promise of value-based care, maybe we'll return to this. I think one of the things that I believe for value-based care to really take off, we need more entities that can make money and have a good track record of doing that. And I think one of the hindrances to that is because there's so much that's new in value-based care, you've got a lot of assumptions you're making when you're building a model, and it's hard to predict how everything's going to sort of pan out, in a 3, 4, 5-year time period as you scale. And so the idea behind having a fee-for-service chassis was we know what's within the 4 walls of a clinic, and so it's not like I have 2,000 assumptions in a model to figure out how we make this thing profitable. I know what we make in within this practice today, and then I only have a few assumptions as I take a patient and flip it to full risk. And so it's allowed us to really have a better understanding and grasp of where we should invest, how we should invest, and what the implications are going to be for that. And so with that in mind, we again did a fair amount of acquisitions. And then last year, we've done probably more organic and de novo growth within our platform. So to date, we've got about 200 providers. We see about 350,000 patients in 6 states. And most of our providers are podiatry, wound care, vascular care. We're adding some other specialties here in the future as well. And what we really care about is specialties that have a close relationship, tight relationship with patients and have a whole lot of visits that typically corresponds to having a chronic illness. And so therefore it's not going to end. And so that's how we've sort of built this model, and then we'll put all the wraparound services around those specialists. And so we spent the last, call it sort of 4 years building that out with the aim of moving to risk, which we did this year with ACO REACH. We started obviously in January with that and have enrolled, roughly 40,000 members have signed up. Now, not all of those necessarily get aligned to us, but to date we've got about 20,000 aligned members, but a ton of room to grow because of our 350,000 patients we see, about 80,000 of those are straight Medicare, and the Medicare Advantage is the biggest sort of opportunity, which we'll hopefully work on as well.
Yeah. So I like that stair-step approach where you have the opportunity to play in a lot of different places, different types of contracts, different types of patients. Like you said, you can take sort of all comers in the community, but you still have this forward leaning towards value-based care to figure it out, because we're all figuring it out. Your example even of ACO REACH, right? New program. We'll see how it goes. You've got the ability to sort of hedge your bet, but at the same time push forward to move the models forward, and hopefully the care too, obviously, is number one.
Yeah, and it also allows us to be flexible and iterate, because there's so much iteration happening within value-based care, right? So if ACO REACH tweaks this way or that way, we have 80,000 Medicare fee-for-service members that we were making money on, right? And so we can be flexible in how we invest and do those types of things, which, I think it's your background working in CINs, probably a lot of parallels there.
Yeah, and certainly it's what the federal government's hoping for, right? Is that we iterate along the way to figure out what the best approach is for the patient.
That's right.
And still have that business proposition that you talked about, which is how do we make sure that our providers are able to stay in their communities with a reasonable business model to sit on top of.
That's right.
One of the things you talked about that caught my attention was this concept of the chronic disease and looking for patients with multiple touch points. So as we know, so much of value-based care historically has been built around the primary care physician, right? Even though, as you also pointed out, the majority of the cost may occur somewhere else, but as that quarterback, orchestra conductor, the person in charge of all things. Talk to me a little bit about how a high-intensity view of the patient from a specialist interacts with the primary care doctor, who may have been, originally intended, theoretically at least, to be more of the hands-on frequency.
Yeah. So one of the things we saw, and one of the initial sort of tenets of founding Upperline is that we knew in the data and sort of anecdotally that the sicker a patient is, particularly with chronic illnesses, the more specialists they see, and the more specialists they see, the less they see their PCP. So on average, about 50% of Medicare members, if you see 2 or more specialists in a year, will not see their PCP, right? So, ironically, the patients who are most in need of care coordination are getting the least care coordination, which, is sort of intuitive when you think about it. If you're going to your podiatrist 4 times a year, your endocrinologist 4 times a year, and your pulmonologist 4 times a year, what are you going to give up? It's probably your PCP for a lot of these patients. And so a lot of the patients that are falling between the cracks and that aren't getting proper care coordination, it's not that they're not interacting with the healthcare system. They're actually interacting quite a bit. They're taking a fair amount of sort of responsibility for their chronic conditions by seeing these specialists. We are just not doing a great job as a healthcare system of meeting them and interacting with them the way that they're choosing to interact with the healthcare system, right? So like we might draw it up that we want patients to sort of flow a certain way, and that's just not how it works, right? Healthcare is complicated, people are complicated. That's right. That's right.
And we show up on time. We don't have any trouble getting there.
That's right. Like, and I think it's pretty well published at this point. That's increasingly, again, we might come back to this. We are huge fans of the PCP-centric model. We believe firmly in that. We love, sort of small census, really high-touch PCP groups. We also know that there's already a supply-demand imbalance with PCPs. We know that a whole bunch of patients are not interacting the way that we might want them. And we know younger generations, as they keep aging into Medicare, that is becoming more and more frequent, right? That we're kind of choosing healthcare as this buffet. And so, we basically say, hey, we want to acknowledge that and let's get a solution for that, right? PCP model, we love. It is a fantastic tool, but it can't be the only tool because you got another 70% of the healthcare system that we've got to figure out how to engage and get in sort of in these value-based care arrangements. So that's kind of the way we see the world as, we need the PCPs, but we also need the specialists, and we need to collectively meet patients where they are. Right. And so we will co-manage all of our patients with the PCPs. Most of our patients do have primary care doctors, and they love us because we're taking, patients that might take an hour in their office, and in the fee-for-service world, as we already talked about, it's hard for them to do that. And these are patients that typically are going to be 2 or 3 times as expensive as their average patient. We can provide home visits, 24/7 call, and things that a traditional primary care office right now is not set up to do. So we're really putting an extra layer of support, extra sort of eyes, ears, arms around their sickest patients, but coordinating with them, right? So part of our medical director's job is to know who the PCP is, know their nuances, right? As a PCP, this one wants to be really involved in things, right? And so we'll call them before we do anything, as opposed to another one who, we might have a great relationship with, right? And they want us to adjust things. And so, it is about having that personal, really primary care relationship as well, and navigating that. And I think all specialists, if they're going to be successful, probably have to do that. We just have to do a little bit more of that.
Yeah, I want to pull on that thread a little bit. So specialists historically have not necessarily been trained to take on as much sort of holistic care,
Yep.
right? So talk to me a little bit about the type of physician practice you're eager to work with,
Yep.
and what it takes as you start thinking more holistically about the patient, and even then how that moves you towards specialists thinking about taking risks.
Yeah. So today, the types of specialists that we're targeting, as I mentioned, are ones where they've got a whole bunch of visits, typically 4-6 times a year for a chronic condition. And that's really what we're targeting. We're targeting that relationship, that frequency of visits. Different than maybe a PCP model, we're not trying to go change their behavior. We're not asking them to manage the patient comprehensively. We do want them to think holistically about the patient, but we're not asking an endocrinologist to manage their COPD, right? Or weight loss, right? But what we are saying is, hey, you've got 4 visits a year for a very sick patient with, a polychronic, you got a laundry list of different conditions, and you're seeing them 4 times a year, right? So rather than just focusing on one thing, we've got a whole bunch of visits within our healthcare system, really, that are underutilized, right? That are focusing on a narrow sort of band. And patients oftentimes don't realize that, right? Like they you're doing a full physical history and assessment, and patients don't necessarily realize that they're really only focusing on sort of this narrow
One body part.
Yeah, that's right. And so we see it as just a massive inefficiency actually in our healthcare system, right? So we've got all these visits happening where we could be talking to them, or at least collecting data and sharing data about the whole patient and engaging with the patients. And so that's what we're trying to lock onto, but we're not necessarily trying to change the specialist behavior per se, because we're targeting ones that have a lot of these visits. What we do change is, I'd say in terms of who we target, we obviously don't want ones that are negative in a value-based care arrangement, right? So as we partner with folks, we're not gonna, buy or hire or build with different practices that are doing things that we would stop in a value-based care arrangement. So that's where we look very different from a traditional fee-for-service models. We don't want to have to cannibalize ourselves in the future. And so, to put that sort of in practical terms for sort of a sick diabetic patient who sees a podiatrist, There's different ways to do wound care. There's some very, very expensive wound care. And then there's ways to do it in a much more cost-effective way. And so we're going to probably find the people naturally in our platform that do it in a cost-effective way, so that I'm not having to change their behavior, right? And so we've selected specialists with that in mind. And then again, what we're really saying is, hey, keep seeing your patients a lot. They trust you. They really, really like you. And we'll put our care team around you, right, in your office, in your clinic. And not ask you to change a whole lot of how you're practicing medicine, which is, I think, really well received, as you might imagine. But we are saying, hey, understand what our full care team can do, right? So talk to your patient about, the pharmacist, right, and the dietitian services, because you do see all their meds, you do see all these things, you do talk to them, you hear these things. You might not want to treat it, but if they're wheezing and they have COPD based on their meds, talk to them, make sure they call our care coordinator, and we can get an NP out there that same day and prevent an exacerbation from happening. And I think they find that really, really rewarding, because historically they're not actually doing those things, right?
Well, they didn't have a way to address it if they did find it.
That's right. That's right.
And that is, frustrating as a physician to see problems you can't address.
That's right.
And so it sounds like you're also bringing to the table new options for the clinicians, the whole care team.
Yep.
So that if they find problems, they're able to address them more on the spot and with tools that work.
That's right. That's exactly right.
So speaking of tools, we've talked a little bit about people, and certainly it sounds like there's probably some process change that goes along, or enhancements as practices come on board, and you think about a model that works across many states. Since healthcare is delivered locally, we still have to localize it. Have you found that technology is playing a role in how you're able to manage this business differently, but then more importantly, manage the clinical outcomes? And I would hate to forget also the workforce. We know they have become so burnout. There's so much that we learned during COVID about what was already happening, how tough their life was. So are there ways that you're finding, rather than yet another burden, technology is actually creating the underlying business tools and platform that you need?
Yeah, great question. So I think from a macro standpoint, how I think of the promise of healthcare technology, I think on one hand it's oversold, on one hand, the other hand it's probably undersold. So I think where it can be oversold within sort of narrow focused service offerings is that, as you said, healthcare at the end of the day, it is local, it is personal, and it is a service industry, right? And so, we think of that relationship as being the most important, the provider and patient relationship as being the most important sort of aspect. And technology can really, really help that in a whole host of ways, which we can talk about. But it doesn't replace that, right? And so the example we always use is, I could give a really fancy Apple Watch to our patient in rural Alabama who's diabetic, and it could blink bright red when their glucose is off. But if they're in rural Alabama and they're not talking to a provider and a dietitian and somebody on our care team, and they just get a call from a call center, it's not going to change their behavior, right? It's not at the end of the day going to do anything. That, with a care team who's engaged, who knows how to use it, who has a great relationship with the patient, like that's where the magic starts happening, right? And so I think we're starting to get there as technology within healthcare, I think, matures, but they have to sort of be really tightly paired with the relationship. That's right. Yeah. Where I think, from sort of my perspective, where it has the most promise, particularly in value-based care, is going back to what we talked about earlier. I think one of the chief existential threats of value-based care is we need more models that can show they can make money. And I think, as sort of the early phase 1, phase 2, whatever phase we're in of value-based care, they have sought to solve largely a clinical or some sort of MLR type problem. And I think the good news is we've seen really good results, right? Like if you build a certain type of care team, you can manage to really low MLR. You can lower, the spend for an ADK for expensive, polychronic patients or end-of-life patients. We've got great results on that, which I think was the intention really of phase 1. I think now we've got to say, all right, what we invested in the care team to get those outcomes actually is really, really expensive, which is why a bunch of these companies aren't making money. And so how do we get smarter about using those resources while getting the same outcomes? And I do think that's where technology is probably has to help us solve this. We have to move away from, we're stratifying our patients in, high risk, medium risk, and low risk, right? And high risk patients are going to get seen every 6 weeks, and low risk patients get seen, once a year or something like that. And moving towards something that's a lot smarter than that, right? Maybe you get 15 different flavors of risk categories, and you can get really targeted in how you're interacting and investing in the care team, right? So, you might have some patients that do need to be seen every 6 weeks, but some that might prefer, the care management and texting, right? Like that might be which is way more cost efficient. Or you might have certain patients that love remote patient monitoring, and that is really, really promising, but we got to target the right patients to do that, which is cheaper than, sending an NP out to the home. And so I think as we get some more repetitions with all these different technologies, but also just get better with the data and technology and sort of actuarial side of things to be able to segment folks and see what's actually changing the spend and behavior and outcomes, we'll be able to be much more efficient with our care teams. Because again, I think right now the care teams have great results, but they're really expensive on a unit economic perspective. So I think that's sort of my macro opinion of technology and value-based care. As it relates to employees, that's a great question. And I would say, similar to my first answer is, it's can go both ways, right? So I think having a whole bunch of technologies where you've got care managers flipping between 4 different screens, probably contributes to burnout, right? And makes it really complicated for them to figure out, what am I supposed to do every day, right?
Because how many times do I have to log in? Which screen should I look at?
Right. Yeah. That's right. That's
deflating.
That's right.
To think I could be doing a better job if only.
Yep.
And so giving them a different work environment becomes really important.
Yeah. And I think we're getting towards more consolidation, where you're getting single platforms like Innovation, that are having a whole bunch of it's one single ecosystem, right? That folks are logging into, and these things are feeding into it, so that a care navigator or a nurse or a social worker doesn't have to remember all of these different vendor alphabet soup that exist out there. We're getting there, right? And I think as we have more of that sort of single platform, their lives are going to get so much better, and they'll get really excited about these things, right? Where they can, imagine a world 10 years from now where they've got an awesome portal, and we've, effectively risk stratified this patient. They know what this patient really wants is a text, right? And we can easily text, in one system. I think that is exciting. We see glimpses of that already, I would say, which is certainly exciting for the team, I think.
Well, so you've talked about 3 of the areas that we wholeheartedly agree. Data, right? You have to sit on top of a strong foundation. You have to have confidence in what that data means. It has to be fresh. It has to be accessible. We call that the patient 360, the ability to see that patient from so many different angles.
Yep.
You've talked about the actuarial science and the advanced analytics that are here and are getting more and more precise. But as you said, we haven't even seen what that will be able to do yet. And then I think you've talked about those workflows.
Yep.
How do you help at the end of the day that the person who is actually engaged with the patient and each other, right? This is also care team to care team, being able to talk to each other. One of the other parts that you brought out was patient engagement. And it's certainly something everybody is trying to find the holy grail of. We have retail models coming in with CRM. Let's make this feel as easy as going on to an Amazon account or ordering your food delivery.
Yeah.
How are you really feeling about where that's going, how possible it is, this sense of hyper-personalization, longitudinal engagement?
Yeah, it's a great question. I think it's will be hard for any provider group to be successful without patient engagement, right? If you're ultimately at risk for patients who are not engaging with you in any different way, then you're not going to change their spend in all likelihood, at least at scale. One of the things that I think we have found, which is unique, I think, to us as specialists, the way that we're attributing patients and having patients be in our risk model is almost exclusively voluntary alignment. So again, because we have to, different than sort of a PCP model, if you walk in our clinic, you will see about Upper Line Plus and the services you can get, and patients are asking about these things. So they're not auto-enrolled, they're not finding out about it via a care navigator, calling, a letter in the mail. Like that's not the first time, right? They've asked for this service. And so, our sort of launching point is fundamentally different than some of the other sort of, again, these auto-enroll, not necessarily up to the patient. And because of that, we've got 70 to 80% of our patients, when they're having the conversation, they want these services.
That's an incredible
right?
average.
Yeah, so it's worked really, really well. And again, it's actually saved us, particularly if you think about the infrastructure you have to build on the back end to engage these patients, right? For some of these other models, because even though you might have a patient that you're at risk for, they don't know it, right? And you've got to figure out how to get in touch with them and call them and see them. And we've, effectively done away with that because the patients are asking us. And so we think it's a huge advantage. We think it's something that hopefully we can see more of within certainly CMS programs, but also within MA programs and other commercial programs. Because at the end of the day, we probably want the patients to be able to choose which risk arrangement and comprehensive program they're in. And I think, for folks that are running programs like Upper Line, it also makes our life just so much easier, right? We're not having to convince the patient that you need these services, which can not be well received. It's a little bit paternalistic, right? There's a whole bunch of, can look Big Brother-esque, right? Like the sales claims data.
Attribution.
Correct.
What do you mean by attribution?
Correct. That's right.
Who attributed me to
That's right.
what?
That's right. That's right. The caregivers get, upset, like, why are you calling, a patient's not sick, right? Or my father's not sick, or whatever.
Because my business says I need to.
That's right. That's right.
So bringing them in. Well, a piece of this also in patient engagement sits fundamentally in social determinants.
Yeah.
Certainly, the type of specialty you do, you are one of the people that have in fact seen this from, it's not new to you,
Yep.
right? It's the world that your care team has lived with for a very long time.
Yeah.
But what are you seeing that might be new, helpful, different, that gives you some hope that we're going to start to see a different type of health equity?
Yeah. So I think first is the data side, right? So we are increasingly, and I think really over the next year, in large part with some of the tools that Innovator's building, where we'll be able to know when a patient walks up, right, that they're from a zip code that likely indicates different things, right? And we know, it's pretty well established at this point that there's a lot of health outcomes that follow all of that. And I think just making our staff and everyone aware of that so that they can access that and be thinking of those things is probably step number one, which we're essentially almost there within being able to have that in our system where everyone's seeing it, where everyone's thinking about it. So I do think the data around this is great. As we think about our patient population, if you look at our sort of avoidable hospitalizations, our poor PCP engagement, all the things that are going to be indicators of spend, it generally is always correlated with some sort of social determinant of the health outcome. And so I think we believe that has to be something that you're fundamentally looking at as you're putting a patient into sort of a care program, right? I think as a result of the focus on social determinants of health, we're also getting much better, particularly from CMS, but much better focus that we should invest resources on things that are not directly healthcare related, right? Majority of the time our social workers are spending might be on getting a ramp for an elderly person, or getting plumbing in their house with Habitat for Humanity, those types of things which don't directly cause a hospitalization necessarily. They could, but they certainly impact their overall health, right? And I think the focus, particularly from CMS around all of this, I think is allowing folks like us to invest resources in it, which is new, right? That didn't exist.
It's new
10
and
years ago.
it's much deserved
Yeah.
from a timing in the world standpoint.
Yeah.
When you think about CMS, you've worked in a governor's office. You know how impactful a state can be as well as the federal government. Where do you think the government, I'll use big air quotes there,
Yeah.
both at a federal level and a state level, could be pushing harder or more creatively on programs and reimbursement models, just
Yeah.
the way that they could use their clout?
Yep.
And it's everything from the data they themselves have to how they design a program and
Yep.
incentivize people. So if I were to say you got to be in charge for the day,
Yeah.
how would you think about that?
Yeah, so my dream world, as we're talking about value-based care, what we're really talking about is incentives for providers right now, which obviously we have a lot of hope that will change the spin curve of the healthcare system. But the most important constituent is the patient, right? And we haven't done a whole lot to change the incentives for patients. It's way more complicated. It's really sticky, right? It is fraught with all sorts of political ramifications of discrimination, of favoring certain groups over others. But at the end of the day, like, we haven't really touched that, right? There's not a whole lot of incentives and structures out there, whether it's at the state level or the federal level, saying, hey, if you behave this way, there's some sort of incentive, good or bad, right? And we could talk about, good is probably
our health got better or worse,
correct.
right? That
That's
was
right.
the ultimate incentive.
That's right. Yeah.
That was the assumption that would be enough and it would overcome all the other barriers.
But it doesn't, right? Even like the most educated, doctors, right? Like, people all struggle with self-discipline
Yes.
and making sure that they can do
I don't know about you.
today. Well, you walked a mile to get here. But most people, even when they're the best educated, have all the knowledge of the world, like, they still struggle to do today what they want for the future. Most people don't have that knowledge, though, right? Like, it's a small fraction, and so I think the incentives on an individual basis certainly matter. Our healthcare system still is largely built and focusing on treating sick people, right? Like, we're not really preventing a whole lot on the whole. You see pockets and things, that are popping up. But again, the incentives, aren't necessarily there on a patient level. And certainly even on the sort of the payer side, and as well as maybe the vendor side, on the payer side, obviously we've got MA, which does have incentives to do value-based care and create value. But commercial doesn't really today, right? At least not on the scale that we're talking about. And as long as patients, most of us are tied to an employer, we're going to be switching insurance also often, and those types of things. So I think there's a bunch of stuff that would have very interesting political ramifications at a state or federal level, that I would love to pilot, some incentives on a personal level. And I do think one of the advantages that the federal government in particular has, CMS, and they've been really, really good and intentional and transparent about this, is they can play the long game, right? In a way that commercial, for-profit entities cannot, right? And they can think in terms of decades, and how we can gradually move people, because it's a $4 trillion part of our GDP, right? It's not going to move quickly. Individual habits, provider habits, payer
Double
habits.
digits, right?
That's right. And so their ability to think in terms of decades, right? I think is actually probably one of the more encouraging thing to me, right? They are consciously, saying, hey, we're going to lead with carrots, and we're going to slowly get here, and then once we get enough adoption, we can do this.
Scale takes a different mindset.
That's right. Yeah, that's right.
So you're a serial entrepreneur, which is exciting. Innovator, actually, our name comes from Innovation Accelerator.
Okay.
So this concept of innovation is really at the core of who we are. And I always love talking to an entrepreneur because by definition, you're always looking around the corner.
Yeah.
When you think about the role of entrepreneurs in healthcare, and sometimes this is a sticky topic because it involves often things like outside investment, different business models than maybe a not-for-profit, long, 100-year-old health systems are used to. Talk to me a little bit about that mindset that you bring to the healthcare ecosystem and what the role is.
Yeah, it's a great question. I sort of maybe sort of classic liberal economist philosophy of this, that I do believe if you create a market that allows itself to set prices, it will find efficiencies and it will find ways to operate more efficiently. I tell our team all the time, like, there's nothing to be ashamed of. I would say that you've got for-profit investors. I think generally for-profit groups and investors like this and VC-backed, PE-backed groups, they're really good at finding efficiencies, right? Like that's their sort of bread and butter, right? And I think that's part of the reason why they're so attracted to healthcare, right? Because we know it's massively inefficient. And so I actually think that is the right antidote, is allowing more market dynamics to be at play. Healthcare is not a free market. And
One of the least free, and so few people
right.
realize
Yeah.
how regulated it is.
Yeah.
It's everything, from the federal government to the Nuclear Regulatory Commission coming in and looking at your imaging equipment.
Yeah. It's so highly regulated, which makes the investment side even more complicated, right? Because there are segments that might operate like a free market, and then there's other things that are massively regulated. You can't touch. But I do believe a lot of the innovation is coming from sort of entrepreneurs that are have creative sort of VC backing and folks with that mindset coming behind them, because it's worked in most other industries in our economy and in our society. This is probably one of, if not the least efficient. And I, so that's where I actually believe a lot of the promise is. It doesn't mean there's not some risk, and there can be unintended consequences for sure. Free markets can cause some bad consequences. We should be aware of those things and be thoughtful about those. One of the things I actually think CMS is really, really good at, for how broad it is, it's fairly good at thinking of the unintended consequences and the ripple effects of these things, which is part of the reason why people probably complain that they're moving slow. But it's like, well, you're moving through this massive, part of our community and our ecosystem.
You have a tremendous responsibility.
Yeah. And so, I don't think about the DME vendors and how they're impacted by what we're doing necessarily, but they have to, right? And so I do think it's nuanced and complicated, but I feel optimistic. I think we've got the right sort of group of people.
I can see why you feel optimistic. You've pointed yourself towards two of the tougher problems. End of life, palliative care, so critical, and for anybody who's been through that end of life journey, we certainly understand the blessing it is to be able to work with somebody who understands what's going on at that stage. And now you've pointed yourself towards, chronic, tough people who need help for years with maybe no chance of true recovery, but a better life, to be able to have a more whole, complete way of going through the world. Along that way, you've probably, with as much as you've pointed yourself towards tough problems, learned a few lessons. Are there things you would want to share with other entrepreneurs and those that are working, in this space that maybe if you had a do-over card, how would you use that?
Yeah, it's a great question. I think probably two things. The first is entrepreneurs probably by nature are pretty optimistic, and we like to try a lot of things. And I think there's a time to try things and then a time to focus, and being able to switch those two levers on and off at the appropriate time is important to say, hey, early on we're trying to figure out how we can best add value. We now know how we're going to best add value. We tried 10 things, we actually now need to do one. And so I think that's been very true for us. I think within healthcare and value-based care, where you're iterating so much, being able to do that and focus on something is really, really important. The second, I would say, is with us is figuring out how to get the right doctors earlier. So I think our two medical directors that we have on the value-based care side and the podiatry side, If you think about sort of the recipe for success, I think it's patient engagement and probably provider engagement. Without those two, you're not going to be successful in these models, or your success will be limited. We have seen the benefits of having those sort of physician leaders on board. The faster they're on board, the more they can build a team around them of other doctors who can lead others. In healthcare is this, very interesting sort of dyad, right, of ops and providers. And I wish we had hired both of them when we started, a while ago. We'd probably be a couple years ahead of where we are.
Great answers. Well, our listeners always like, one good takeaway. So if you think about the next year, where would you tell those that are listening to be pointed? What should they be paying attention to that they might not be?
So for us and for the healthcare system, I would say think of specialists in ways that you have not traditionally. And so what I mean by that is especially value-based care is newer. Traditionally, folks are thinking about it in terms of the amount of spend that the specialist can impact, right? So an oncologist or nephrology, because that's the majority of the spend for those patients. That's not the way we're looking at it. We're saying, hey, where are the patients going? And they have a lot of interactions. And there are a lot of specialists where that's true. I think a huge number, we're talking tens of thousands of them, where these are the sick patients that are actually falling between the cracks because they're going to these specialists quite a bit. And I think what we're doing can be done in a lot of other areas. If we're going to get to 100% of Medicare's members at full risk by 2030, we got a long way to go, and we're going to need a lot more groups thinking about this and being a lot more creative in how we outreach to patients. It can't just be what we've done historically because we'll stay at 30%. So I think there's just a tremendous amount of sort of opportunity within not all specialists, right? I'm not saying every surgeon under the sun, they don't have that type of relationship with the patient, but there are a lot out there. And we talk to the specialists all day. They haven't even really been thinking about this, right? Like they haven't been asked, hey, could you leverage that relationship you have with your patient in a different way, in a bigger way, in a more exciting way? And so I think hopefully we'll have more of those conversations and it will spread over the coming year.
Well, David, it has been a true pleasure. This conversation has certainly energized me, and I'm sure our listeners have found it similarly. Thank you so much for joining us today for this version of Accelerate. We were joined by David Thorpe, co-founder and CEO of Upperline. Please join us again, as we'd love to have you with us.